So, good evening all of you. I hope I'm audible and visible. Please give me a thumbs up everyone if my audio video is clear to all of you. Please give me a thumbs up if my audio video is clear. Okay. So, welcome everyone on the NEET PG channel of Unacademy, that is Let's Crack NEET PG. I am Dr. Chesta Agarwal, your dermatology educator on Unacademy, and I have myself scored All India rank 261. So I will give you the tips and tricks which I have used to crack my exam. So I request everyone to please follow the today's session. This will be a very interesting session where I will discuss with you all the important frequently asked MCQs. Okay. So all the students are requested to be with me for the next 1 minute or so. So 1 hour or so, because we will be discussing the important sessions. I hope my audio video is perfect. All right, there is no issue with that. Now, a little bit about Unacademy. This is the online platform for the preparation of NEET PG. Now, please remember, Unacademy is one of the best online preparation channel for the preparation of NEET PG. Now, after downloading Unacademy from the App Store, you have to choose the different subjects or you can choose for the different courses. So you have many courses with you. For example, in this month of January, we are coming up with very interesting courses, and these are the target batch for FMGE, the target batch for next exam, the evening batch and the morning batch. So we will be starting all these batch courses soon. So I request all the students to please be with me or please join any of these courses, and you can use my referral code CHESTA10. So requesting everyone to please be with me for the next 1 hour so that we can discuss the important questions. And if you want, so hello everyone, Kaustubh, Swapan, Srinivas, welcome everyone. Now the next is we are about to start a batch course, or we have already started a NEET PG combat series. The first exam was on 15th of January and it has covered all the first year subjects. Now the next Unacademy combat is on 24th of January. Here we will be taking care of pharmacology, pathology, forensic medicine and anesthesiology. Now this is absolutely free for everyone. We will be giving you 45 questions which you have to solve over a period of 60 minutes. Now this will be a very important session for everyone. So I request all the students who will be giving the NEET PG exam subsequently to please be a part of this batch course or this Unacademy combat. This is absolutely free, but you need to get enrollment using my referral code, that is CHESTA10. So please enroll this batch course or enroll this Unacademy NEET combat, which is free, using my referral code CHESTA10, or even you can use DERMA10 as the referral code. Now we have two types of subscriptions on Unacademy. One is the Plus subscription, which gives you the access to Unacademy, and another is Iconic, which gives access to Unacademy as well as Prep later. Now on Unacademy, if you take Iconic subscription, it is around 55,000 rupees for 1 year. But the same subscription is of 49,500 if you use the referral code CHESTA10. So requesting everyone to please follow me, use my referral code. The next is Iconic subscription, which the Plus subscription, which have a 1 month subscription, and this is best for your NEET PG preparation 2021. So the batch course, which is of 5,000 rupees, you will get the same batch course in 4,500 rupees if you use my referral code CHESTA10. So that is all about the important notices. Now starting with the first question of the today's session. Everyone, please look at the first question on your computer screen. Try to answer this question. These are frequently asked questions. Everyone, please answer the first question. Please answer the first question. Identify the simple bedside procedure that is shown. Bullous spread sign, scraping from KOH, slit and smear technique or diascopy. Very nice. Yes. So please remember, this is a very easy or simple bedside investigation which is done for checking the blood vasculature. The erythema is because of the blood supply, or this is because of some of the extravasation. So this is a classical test which is called as diascopy. Please give me a thumbs up if you all understood. Everyone give me a thumbs up. I hope this is clear to all of you, please. Yes. So this is a very, very important investigation which is done, and this is a diascopy test. Now, can anybody tell me bulla spread sign? In which condition you will do a bulla spread sign? Anyone can answer this. Where do you do a bulla spread sign? Yes, very nice. I'm very sorry. So the bullous spread sign can be done in the vesiculobullous disorder. Chaos crepine can be done for the tinea or dermatophytic infection. And the slit skin smear technique can be done for the patients of leprosy. Please remember, all of them are bedside investigations which are very, very helpful for your preparation or for your examination. Understood? Very nice. So bullous spread sign is vesiculobullous disorder, can be in pemphigus vulgaris or bullous pemphigoid. Moving to the second question, please answer the second question. Identify the sign which is being shown in this picture. All of you. Very nice. Kaustubh, Naga, very nice. So identify the sign which is being shown in the picture here. Very nice, Srinivas. Very nice, Kaushika, Shri. Very nice, all my students. So identify the sign which is shown in the picture. The correct answer of this question is, you all are right, this is Auspit sign. Now what is Auspit sign? This is a sign which is done in the patients of psoriasis. Now this sign consists of 3 steps. Can anybody tell me what are the 3 steps of Auspit sign? Anyone can tell me what are the 3 steps? The step 1 is something called as grattage test. What is grattage test? With the help of the glass slide, we will rub the lesions. On rubbing the lesions of psoriasis, there is exacerbation of the scale. So this is called as grattage test. Second is, when you rub the scales, there is exacerbation and they will give you an appearance which is called as candle grease sign. So what is it called? It is called as candle grease sign. And on removal of the scale, you will see a thin shiny membrane which is called as Bulkeley's membrane. And when you remove this membrane, you will see pinpoint bleeding hemorrhages. Very nice. I think everybody is right for this question. So this is called as Auspit sign. Now can you tell me in which condition you will see Darrier sign? Anyone can answer? Yes, Darrier sign is seen in the patients of urticaria pigmentosa, which is cutaneous mastocytosis. Okay, urticaria pigmentosa. Now what about Esbo-Hansen sign? What about Esbo-Hansen sign? Yes, it is similar to that of the bullous spread sign in vesiculobullous disorders. And can anybody tell me in which condition you do Fitzpatrick sign? Anyone can tell me where you will do the Fitzpatrick sign? Please give me a thumbs up if you can know this. So Fitzpatrick sign, which is also called as dimple sign, it is done in the patients of dermatofibroma. Okay? So it is done in the patients of dermatofibroma. Very, very important for you. That is Fitzpatrick sign or dimple sign. All these points are very important for you in the exam. So please try to remember it. Moving to the next question. This toxic mediated disease is most commonly caused by. So everyone please answer this question. So which disease or which infection causes this type of clinical presentation? What is seen? Here you can see flaccid bullae plus there is turbid fluid. Turbid fluid. So flaccid bullae with turbid fluid, it is the characteristic feature. Can you tell me the diagnosis, Kaustubh? It is not staphylococcal scalded skin syndrome. This is a classical example of bullous impetigo. This is nothing else but bullous impetigo. Very important image based question. And bullous impetigo occurs exclusively secondary to Staphylococcus species. So very nice, Naomi, Srinivas, Kaustubh, Kaushika, you all are right for this particular question, that the toxin mediated disease is most commonly caused by Staphylococcus. Okay? Nothing else to discuss here. Moving to the next question. Quickly answer this question. Which organism is responsible for the condition depicted in the photograph? So you can see a clinical image and you have to tell that which is the organism which is responsible for this type of clinical presentation. Trichophyton rubrum, Trichophyton violaceum, Malassezia furfur or Trichosporum beagley. Anyone with the answer? Kaustubh, can you answer this question? Very nice, Srinivas. So Kaushika is also right, Naomi is also right, and Kaustubh is also right. Please remember the correct answer is Malassezia furfur. What is this clinical picture showing you? Anyone? What is this clinical picture shows? It shows the infection which is called as Pityriasis versicolor. Where do you see Pityriasis versicolor? Secondary to which infection? So please remember Pityriasis versicolor occurs secondary to Malassezia. It occurs secondary to Malassezia furfur or Malassezia globosa. Can you tell me which species is common? Furfur or globosa? Anyone? Which is common? Yes, very nice. It is the commonest one is the globosa. Okay? And you are very correct, Srinivas. Here you have something called as Besnier sign. Very nice. Can you tell me what is the Besnier sign seen in the patients of Pityriasis versicolor? Anyone? What is the Besnier sign? Which means that when you scratch the lesion of Pityriasis versicolor, please listen carefully. When you scratch the lesions of Pityriasis versicolor, there is increase or accentuation of the scales, and this is called as Malassezia furfur or the Besnier sign. Okay? I hope this is clear. Tausif, Srinivas, Kaustubh, everyone, Naomi. Moving to the next question. Yes, this is also called as scratch sign. You are absolutely right, Srinivas. Please answer the next question of the today's session. Please answer the next question, all of you. A 35-year-old man who is farmer by occupation develops the curvilinear lesions over the third web space. So the lesions are present over the third web space. What is the diagnosis? Scabies, pediculosis corporis, cutaneous larva migrans or myiasis. So anyone can answer this question. Very nice, Naomi, Srinivas, Kaustubh, very nice. So, and Srinivas, you are also right about the infective cause, and Tausif and Chirag, you all are right. This is a classical case of cutaneous larva migrans. Please remember this clinical picture is very important. Can you see there is a lesion which is present here which is curvilinear. This is the path which is followed by the larva. So larva follow these path and this is associated with intense itching. Okay? It is associated with intense itching. Can anybody tell me what treatment you will give in these patient? Anybody? What treatment you will give in these patient? You will give albendazole plus ivermectin. So a dose of albendazole or ivermectin stat dose can be given in these patients. Okay? So I hope this is clear to all of you. Please give me a thumbs up if you understood this point. Okay? Everyone give me a thumbs up if you understood. What is myiasis? Naga, please remember myiasis is what is called as the housefly, the eggs of the housefly. So that if whenever there is a humid environment or moist lesions, there is development of the eggs and this will lead to myiasis. Okay? I hope this is easy. How to differentiate cutaneous larva migrans and burrow? Please remember, Kaustubh, the curvilinear appearance. Can you see this is curvilinear? So curvilinear appearance is very, very classical for the cutaneous larva migrans, but for the patients of scabies, it will be linear. Okay? Please give me a thumbs up, Dr. Kaustubh. I hope you understood this point. This is very, very important. Please give me a thumbs up if you understood this point. Okay? Chalo. Moving to the next question. I want all my students to answer this question, a very, very important image-based question, a frequently asked question in dermatology. Okay? So this is a frequently asked question in dermatology. Please answer the question. A 12-year-old male who presented with multiple raised lesions over the left side of the lower abdomen and you can see a clinical picture. The lesions are present in the linear pattern and there are roughly 3 of the groups. What is this sign and the disease called as? Now I want everyone to answer this. This is very important. Very nice, Srinivas, Anju. What about the other students? Tausif, Chirag, Naga. Anybody else can answer this question? A very important question for your exam. A very important question for your exam. So I want all my students to answer this. Yes, so very nice, Kaustubh. What about you, Kaustubh? What is the answer here? Very nice, Naomi. Good. So whenever you see the clinical presentation of 3 lesions, or whenever you see the erythematous papules in the group of 3, this is classically called as breakfast, lunch and dinner sign. So this is called as breakfast, lunch, dinner sign, which is seen in the patients of bed bug hypersensitivity. And this type of dermatitis is also called as Cutaneous dermatitis. Please remember, this is very commonly seen in the hospital settings or in those where the local hygiene is poor. When the clothes or the beddings are not washed frequently, they tend to develop these insects inside the bed lining, and they can have the bloody meals on the human beings in the group of 3. So this is called as Cutaneous dermatitis or bed bug hypersensitivity. So very nice, Srinivas, Kaustubh, Naomi, Arjun, everyone. So what is the treatment? Please remember, the best modality to treat it, first of all, you have to advise the patient to wash all the beddings and to expose the beddings or linings to the strong sunlight first. Second is, for the lesions which occurs on the skin, you have to give topical steroids. There is no need to give any antibiotic, topical antibiotic. Only a topical steroid will be given to the patient, and you have to advise the patient to wash the bedding and to expose the bedding to the hot sunny environment. Okay, I hope this is clear, all of you. Srinivas, Kaustubh, give me a thumbs up. Moving to the next question. Quickly answer this question. Again, a image based session, image based question. Very nice, Tausif. So I'm already getting the answers. I want all my other students to answer this as well. A young adult presented with erythematous erosion over the volar aspect of the left forearm. The similar lesions over the opposed surface of the arm was also noted. Patient recalls crushing of some insect between the 2 surfaces. So what is the diagnosis? Anyone can answer this question. Only one student still now. Very nice, Naomi and Tausif. What about you, Kaustubh, Srinivas? What about you? Very nice, Srinivas. We had more students. Chirag, what about you? Naga. Anybody else want to answer this question? Very nice, everyone. Kaushika, what is your answer? Yes. So everybody, please remember, this is a classical example of Pityriasis dermatitis, which is seen very frequently during the rainy season. Now what happens when this insect get crushed between, or when the insect get crushed or they release some fluid? When these fluid come in contact with the skin, they causes irritant contact dermatitis. And yes, Naomi, you are absolutely right. These lesions are called as kissing lesions. Okay, this is called as kissing lesions because they occurs on the 2 surfaces which are opposing or touching each other or kissing each other. So that is called as kissing lesion. Very classical of Pityriasis dermatitis. So I think everybody is well versed with this topic. Going to the next part. Please answer this question. Very important. A 12-year-old boy, I hope you can see the clinical picture here. 12-year-old boy presented with the following cutaneous lesion. What is the diagnosis? Dystrophic calcification, tuberous xanthoma, nodular amyloidosis, or acral pustular or acral persistent papular amyloidosis. This is A, papular mucinosis. So very nice, Chirag. So I already have my answers. What about other students? What are these yellowish colored deposits over the elbow of this 12-year-old boy? Very nice, Chirag, Naga, Srinivas, Kaustubh and Naomi. This is not dystrophic calcification. This is a classical example of tuberous xanthoma. Can anybody tell me in which conditions you will see tuberous xanthoma? Which type of hyperlipoproteinemias presents with tuberous xanthoma? Kaustubh, can you tell me hypercholesterolemia is which type? Which type? Type 1, type 2, type 3, type 4 or top 5? You are absolutely right, Dr. Kaustubh. It is familial hypercholesterolemia. But if you have to tell me the type, it is type 2A. Okay? So it is seen in type 2A hyperlipoproteinemias. Please give me a thumbs up if you all understood. This is very, very important. And here in these patients you have deficiency of B100 apoenzyme, and that is why there is increase in the cholesterol amount in these patients, giving rise to hypercholesterolemias. Okay, so Srinivas, can you tell me what is the cutaneous lesions in the patient of type 3? In the patients of type 3 hyperlipoproteinemias, you will see eruptive xanthoma, as well as, no, sorry, not eruptive xanthoma, I am very sorry for this. Eruptive xanthoma is seen in type 1 hyperlipoproteinemias. Type 1 hyperlipoproteinemias present with eruptive xanthoma, and type 3 presents with the Palmer xanthoma and xanthelasma palpebrum. Okay, so please remember, this is very, very important. Xanthelasma palpebrum and Palmer xanthoma is a feature of type 3. I hope this is clear to all of you. Everyone give me a thumbs up if you understood that this is a case of tuberous xanthoma which is seen in type 2A. Moving to the next question. Can you tell me what is this sign which is shown in this clinical picture? Anyone can tell me the sign which is shown? Derrier sign, Crow's sign, Hutchison sign, Auspit sign. Yes, adenoma sebaceum is different. Please remember, Srinivas, adenoma sebaceum is present over the face, and that is the characteristic features of tuberous sclerosis. It is never seen over the elbows. Okay? I hope that is clear to you, Srinivas. And Kaustubh have already explained this to Srinivas. Very nice. So what is this? I think everybody is right. Chirag, Srinivas, Kaustubh and Naga. No, this is not option number C. This is option number 2. What is it also called as? This is also called as axillary freckling. This is also called as axillary freckling, which is the characteristic feature of type 1 neurofibromatosis. And what is the name of type 1 neurofibromas? It is also called as von Recklinghausen disease. Von Recklinghausen's disease is the another name for the type 1 neurofibromatosis. Now, can you tell me where do you see Hutchison sign? Anyone? In which dermatological condition you will see Hutchison sign? Can anybody answer this question for me? Kaustubh, Chirag, Sonali, Naomi, Naga, anyone can answer. Where do you see Hutchison sign in dermatology? Nobody till now, nobody. You have 2 diseases. Very nice. So the first, very, very important is you will see it in the patients of acral melanoma. What does acral melanoma tells you? So, Bibekananda, please remember, in syphilis you have Hutchison teeth or Hutchison triad. There is no Hutchison sign in the patients of syphilis. Hutchison sign is seen in the patients of acral melanoma, which says that if there is discoloration of the nail plate and if there is extension of the discoloration onto the nail fold, it tells you that there is underlying acral melanoma. Okay? And the second is in the patients of herpes zoster. What is herpes zoster says that if the lesion of herpes zoster are present over the tip of the nose, there is an increased risk of having the ocular zoster lesions. I hope you all remember, it is not syphilis, it is acral melanoma and herpes zoster. Everyone give me a thumbs up if this is clear. And we have already discussed that Auspit sign is seen in the patients of psoriasis and Derrier sign is seen in the patients of urticaria pigmentosa. Nothing is new. I think everybody is clear with this. I will straight away go to my next question. Okay? What is pseudo-Hutchinson sign? So you have to tell me what is pseudo-Hutchinson sign. Can anybody tell me what is pseudo-Hutchinson sign, Kaustubh? Can anybody help Kaustubh in telling what is pseudo-Hutchinson sign? What is pseudo-Hutchison sign? Can anybody tell, Kaustubh? Anyone can answer this? Anyone can answer what is pseudo-Hutchinson sign? So please, yes, very nice. Please remember, Dr. Kaustubh, pseudo-Hutchinson sign is the same sign which is called in the patients of acral melanoma. Okay. So in the patients of acral melanoma, sometimes you call it as pseudo-Hutchinson sign also. It is not different. Similar to, yes, the pigmentation of the nail bed. What happens in the patients of, sometimes what happens, there is a mere pigmentation, but there is no acral melanoma. So to differentiate them, you have called as pseudo-Hutchinson sign, but it is not seen in the patients of melanoma. In melanoma, it is called as Hutchinson sign. I think this is clear to all of you. Okay, I think this is clear. Please answer the next question. Which nutritional deficiency can occur in the people consuming the following? Thiamine deficiency, pellagra, scurvy, or acrodermatitis enteropathica. So what is this? This is maize or makka in Hindi. Okay? So whenever a patient consumes maize as the staple diet, he suffers with a very classical disease, and that is pellagra. Can you tell me pellagra is because of which vitamin deficiency? Anyone can answer this question. That pellagra is which vitamin deficiency? Vitamin B1, B2, B3, B4, B5, B6. So Chirag, can you tell me what is niacin? B1, B2, B3, B4, B5? Anyone can answer? Yes. So it is vitamin B3 deficiency, which is niacin deficiency. Okay? Now what happens when patient consume maize as the staple diet? Now maize is poor in tryptophan, and tryptophan is a precursor for niacin synthesis. It is precursor for niacin synthesis. So if there is no precursor, you will have no niacin, and hence these patients will suffer with the features of pellagra. Can you tell me what are the features of pellagra? Anyone can answer what are the features of pellagra? Anyone can tell me what are the features of pellagra? Very nice. Yes, you are also right. Vivekanand, please remember there is presence of isoleucine. There is presence of isoleucine in the patients of maize diet, and this isoleucine will inhibit the tryptophan intake or absorption. Okay? Now I was asking you about the clinical presentation of pellagra. So everybody is right. You have 4 Ds: diarrhea, dementia, dermatitis, and death. Okay, so you have diarrhea, dementia, dermatitis, and death. Okay, so please remember the 4 Ds of pellagra. This is very important and can be asked in your exam. And yes, Srinivas, Kessel necklace is the classical photodermatitic lesion of the patients of pellagra, which is seen over the anterior part or the V area of the neck. Now please answer the next question, a very easy question. A 4-year-old girl presented with following lesions. This could be a manifestation of. Now I want all my students to answer this, that a 4-year-old patient present with this, it could be a manifestation of. Please read the question carefully. Don't quickly jump and answer. Please read the question. Everybody is making the same mistake. Dhaval, Naga, and Dr. Kaustubh, all 3 are making the same mistake. Please read the question carefully. Read the options carefully. Can you tell me what is the diagnosis here? Can you tell me what is the diagnosis in this particular patient? Anyone? Yes, very nice. This is a classical case of Phrynoderma. And what is Phrynoderma due to? Please remember, Phrynoderma occurs because of deficiency of vitamin A, vitamin E, essential fatty acids, even essential minerals or vitamin C. So it is not exclusively because of vitamin A deficiency or vitamin E deficiency or essential fatty acid only. Okay? So please remember, Kaushika, Kaustubh, Dhaval, Naga, Naomi, Srinivas, that the correct answer of this question is all of the above. Okay? And what you will give for treating these conditions, you have to give proper food supplements which covers or which take care of vitamin A, E, and essential fatty acid. And for the local cutaneous lesions, you have to give keratolytic agents, like you can give the retinoid, topical retinoids, which will cause exfoliation. You can also give urea or lactic acid combination, which will cause removal of the superficial papules. And yes, Kaustubh, Phrynoderma is sometimes also called as toad skin. Okay? So I think this is clear. Moving to the next question, I want all my students to answer this question, a very very easy question. A 6-year-old infant weaning was started 2 weeks ago, presented with diarrhea and the following cutaneous lesion. What is the most probable diagnosis? Six-month-old infant was weaned 2 weeks since 2 weeks, and now he present with diarrhea and the lesions which is present mainly around the periorificial areas. Very nice. So this is a classical case of acrodermatitic enteropathica. What is acrodermatitis enteropathica? Can anybody answer this? What is acrodermatitis enteropathica? Very nice. It is a congenital zinc deficiency. Now what happens in the mother milks, usually it consists of zinc. So till the weaning or till the 6 month when the infants are exclusively breastfed, there is no deficiency of zinc. But when the patient or when the infant is weaned off the breast milk or started with a top food, then there is sudden zinc deficiency leading to the classical feature of acrodermatitis enteropathica. Can anybody tell me what is the classical triad of acrodermatitis enteropathica? Anyone can answer. So Kaustubh, you are right. You are just missing a 1 point. Can you tell me what is the third criteria of the triad? Very nice. You have periorificial dermatitis. You have periorificial dermatitis. Very nice. They have diarrhea. And one more point which is missing out here is no, it is not F or not D. It is alopecia. Okay, so please remember the mnemonic to remember here is DDA, Delhi Developmental Authority. You can remember it like this. So it is dermatitis, diarrhea and alopecia which is seen in the patients of acrodermatitis enteropathica. Okay, so Sonali, Vivekananda, Tausif, everyone, I hope or I assume that you understood this question. Very very important. Moving to the next question. Now, if you are not able to answer these questions, please get Unacademy subscription because we are teaching everything in detail on Unacademy learning app. So please get your app today, download it, use my referral code for subscription on any of the courses. You can use my referral code Chesta10 to get the subscription. Okay? So please get your app today. Now I want all of you to answer this question. A male child with cryptorchidism presents with large dirty brown scales. Skin shows hypergranulosis and steroid sulfatase deficiency. Anyone can answer which is the correct point here. Very nice, Naomi, Naga. Kostu, please read the question carefully. Please read the question carefully. I want all my students to use my referral code to unlock all the free classes of Unacademy or the paid classes. So please don't forget my name, Chesta10. You have to use this code whenever you want to go for the subscription or if you want to unlock any of the course on Unacademy. Okay? So very nice, Kaustubh. I think everybody understood this. The correct answer of this question is X-linked recessive ichthyosis. Now, what are the points which favors X-linked recessive ichthyosis? First is X-linked ichthyosis have large black color scale. They have large black color scales. That is the first point. Second is it is associated with cryptorchidism as well as corneal opacity. Very important. They are associated with cryptorchidism and corneal opacity. Next feature is what is the enzyme deficient? You have deficiency of steroid sulfatase enzyme. And if you do a histopathological examination, there is hypergranulosis which is seen. So everything is given in the question that there is cryptorchidism with large brown scales. The skin biopsy shows hypergranulosis and along with that you have steroid sulfatase deficiency. So nothing else could be the answer other than the X-linked recessive ichthyosis. Chalo, good. Now let's move to the next question. I want all my students to answer this question quickly. Very, very quickly answer this question. Very nice, Tosif. A patient had 7 irregular hyperpigmented macules on the trunk and multiple small hyperpigmented macules in the axilla. The groin as well as early childhood there was no other skin lesions. What is the most likely investigation to support the diagnosis? Very nice, Naomi, you are right. Can you tell me what is the diagnosis here? Can you tell me what is the diagnosis in this case? Anyone can tell me about the diagnosis? So Naomi, you are right. What about you, Kaustubh, Dhaval, Bibekanand? What about you? What about the other students? Only few can have answered this question. So this is a classical cafe au lait macule. When you see more than 6 cafe au lait, more than equals to 6 cafe au lait macule, along with the similar lesions over the axilla, which is axillary freckling. So both of them are feature of neurofibromatosis type 1. So in this patient, the investigation which you will do is slit lamp examination. And can you tell me why you will do the slit lamp examination? Yes, you will do this to look for Irish leash nodules. Okay, so you will do this test to look for Irish leash nodule. This is very important. And Kaustubh, please remember, in McCune-Albright syndrome you will only see cafe au lait macule, but there is no axillary freckling in the patients of McCune-Albright. Okay, and there is no Irish nodule also in the patients of McCune-Albright. So please remember this. Another point is the cafe au lait macule of McCune-Albright have this type of surface, the rough surface like this. But the cafe au lait macule of the neurofibromatosis have a smooth borders like this. So I can see, you can easily make out that the border is very smooth in these patients. So this becomes a cafe au lait macule of neurofibromatosis. Yes, very nice. Coast of Maine and coast of California. Coast of Maine is like this. So coast of Maine is a description for McCune-Albright, but coast of California. Coast of California is for the neurofibromatosis one. Chalo, let's do the next question. Quickly answer this question, everyone. The question is given on your computer screen. I want everyone to answer it as fast as possible. Very nice. And good evening, Achan. Good evening. Welcome all the students who have joined just now. I request you to please solve the question. A 45-year-old man was presented to dermatology outpatient department with the complaints of excessively thickened skin. Now there is thickening of skin over palm and sole. He gave a history of similar feature in one of his children. On examination, nails were dystrophic in both the hands and feet with thin sparse scalp hair and no hypohidrosis. Please remember, the question says that there is no hypohidrosis, which means that sweat gland is normal. So I think now you can get a clue. Naomi, Kaushika and Achan, this is not option number 1. In which condition you have sweat glands normal? The answer is option number 2. Please remember Clouston syndrome, which is also called as hydrotic ectodermal dysplasia. Okay? This is hydrotic, which means that the sweat glands are normal. But the Christ-Semen-Torrent disease is also called as anhydrotic or hypohidrotic ectodermal hyperhidrotic ectodermal dysplasias. So I think this is very important, that anhydrotic and hypohidrotic ectodermal dysplasias, which is called as Christ-Semen-Torrent. But here the question clearly mentions that there is no hypohidrosis, so this becomes a case of Clouston syndrome or hydrotic ectodermal dysplasias. Now what are ectodermal dysplasia? Please remember, the ectodermal dysplasias are those group of disorders which have defect in the ectodermally derived structures. For example, nails, hairs, skin, teeth, all of these sweat glands, all of these are ectodermally derived tissue, so they have deficiency of any of these component. Moving to the next question, quickly answer the next question for me everyone, quickly answer the next question. Cell culture from the patient with this disorder exhibit a low activity. The autosomal recessive genetic disease includes marked sensitivity to sunlight with subsequent formation of multiple skin cancers. The premature death, what is the diagnosis here? Very nice Naomi, Kaushika, Vivekananda, very nice all my students. This is very important for you to remember, okay? Good. So the correct answer of this question is Xeroderma pigmentosa. Xeroderma pigmentosa, it is a nucleotide excision repair defect. Excision repair defect. What is it? It is a nucleotide excision repair defect which presents with photosensitivity. It presents with photosensitivity, it presents with increased risk of skin cancers, as well as it also presents with increased freckling and scarring of the face or the sun exposed part. Okay? Now can you tell me any other nucleotide excision repair defects you know of? Anyone? Other than Xeroderma pigmentosa, do you know any other nucleotide excision repair defect disorders? Anyone can name at least 2 of them? Can anybody answer at least 2 of them? The nucleotide excision repair. Please answer. This is a very important question. Naga, Achan, can you answer this for me? Yes, so please remember the correct answer is, other than Xeroderma pigmentosa, you have few disease, for example, Bloom syndrome, Cockayne syndrome. So you have Bloom syndrome, Cockayne syndrome, Ataxia telangiectasia, and trichothiodystrophies. All of them are examples of the nucleotide excision repair along with the Xeroderma pigmentosa. Okay? So please remember, this is very important. Let's do another question and see how many of you have understood. Please answer this question. The image shows certain changes in the conjunctiva commonly found in the DNA repair defect syndrome. What is the first clinical manifestation of this disease? So can you tell me what is the diagnosis here? First question is, what is the diagnosis? Anyone can tell me the diagnosis here? Okay, very nice. So I think Tosif and Naomi, only you two are right. What about you, Kaustubh? Do you know this? So please remember, this is a classical case of Ataxia telangiectasia, which we have just now discussed, that this is a nucleotide excision repair defect. Can you see here, there is presence of telangiectasia over the mucosa. Okay? So there is presence of telangiectasia over the conjunctiva, as well as you have similar lesions over the skin. Now because of involvement of the cerebellum, these patients will have progressive cerebellar dysfunction leading to ataxia as the first common presentation. So the first clinical manifestation of the patient is progressive cerebellar degeneration. Okay? So I think only 2 students have answered this, Tosif and Naomi. Rest nobody have answered this question. Moving to the next question, quickly answer this question. A girl child with verrucous lesion at an age of 2 weeks later on develops linear band of hyperkeratotic papules and nodules, followed by world pigmentation. Her mother reports history of in utero child death and hypopigmented atrophic linear lesions. So can you tell me what is the diagnosis? Now how to differentiate cerebellar ataxia and ataxia telangiectasia? So Naga, please remember, in cerebellar ataxia exclusively you will not see any telangiectasias. But in ataxia telangiectasia you will see presence of mucus as well as cutaneous telangiectasias. Okay? Understood? Naga, please give me a thumbs up. And for this question, only Naomi, Kaustubh, Sonali and Naga, you are right. This is a classical case of incontinentia pigmenti. What is continentia pigmenti? It is an X-linked dominant disorder and this is lethal to the male child. These are lethal to male. So the in utero child death, maybe the sex of the child was a male child because it is X-linked dominant. So it causes death of the male. Now what is the gene defect? You have Nemo gene which is defective here. Nemo gene defect. Okay, so it is the Nemo gene which is defective here. Now in this patient the clinical presentation goes in. So in this the clinical presentation have a classical sequence. What is that sequence? The sequence is initially you have vesicles and all these linear lesions are in the Blaschkoid pattern. So first you have the vesicles which are present in the linear pattern, then you will have hyperkeratotic lesions, then you will have hyperpigmentary lesions, and then you have hypopigmentary lesions. So you have vesicles, hyperkeratotic, hyperpigmentary and hypopigmentary. So this is the sequence which is followed. So here the patient says that initially you have verrucous lesion but later they become pigmented and later they become hypopigmented. So this is the sequence which is followed by the lesions of incontinentia pigmenti. Now please do the next question, all of you, the frequently asked questions in dermatology. I hope you all are enjoying these classes, or these questions are very important. If you feel that you are not able to solve or anything you are not able to understand, please get an Unacademy subscription. The referral code is given here, that is Chesta 10. So please subscribe to Unacademy. Answer question number 49, all of you. I hope you can see the question clearly. Yes. Please answer the question, everyone. Vivekananda, Kaustubh, Naga, anyone can answer this question. Very nice, very nice. Anyone else can answer this question? So when a patient develops multiple hypopigmented macules which are arranged around the follicle. So the question says that you have perifollicular macules which are hypopigmented. Now these scales or these lesions are associated with fine scales. And along with that, it tells you that there is a history of recurrence. Whenever you see a hypopigmented lesions which are surrounded around the follicles with a fine scale with history of recurrence, this becomes a classical case of Pityriasis versicolor. Okay? And please remember, Pityriasis versicolor, the organism release azelaic acid which causes dilution of the pigment leading to the hypopigmentation. So for these patients of Pityriasis versicolor, potassium hydroxide staining will be done, and what you will see? You will see a classical spaghetti and meatball appearance. Spaghetti and meatball appearance, which is also called as banana and grape. Also called as banana and grape appearance. So everyone please remember, this is very important, banana and grape or spaghetti or meatball appearance. Let's move to the next question. What is the diagnosis when a patient of obsessive compulsive disorder picks the real or imagined acne predominantly on the face? So what is the diagnosis when a patient of OCD picks a real or imagined acne lesions predominantly on the face as given in the image? So very nice. I can see Vivekanand, Dr. Kaustubh and Binayak, Sonali, you all are right. Dr. Kaustubh, this is a classical case of acne excori. Now what is acne excori? It is associated with obsessive compulsive disorders, especially seen in young females. Now, because of the compulsion to pick or to rub the acne lesions, they tend to develop these type of scarring or hyperpigmentation over the sites of acne, and this is called as acne excori. Now here please remember, along with the anti-acne therapy, you have to give behavioral modification therapy in these patients. Otherwise, if once the acne is treated, again when the acne will occur, the patient will do the same thing, so there will be no improvement. So you have to give a behavioral therapy, behavioral modification therapy in the patients of acne excori. Okay, so I think this is clear, there is no confusion. Let's go to the next question. I hope you can see the clinical image clearly. I want all my students to answer. A 25-year-old patient who presented with hair loss to your clinic. She gave a history of thyroid disorders around 6 months back. What is your clinical diagnosis of this patient? Very nice, Binayak, Dr. Kaustubh. What about the other students? Sonali, Naga. So only one student is right till now, and that is Naga. The correct answer of this question is telogen effluvium. It is not alopecia areata. Understood, Binayak, Kaustubh and Sonali? Whenever you have a history of thyroid disorder and after which the hair fall start, it means that there is telogen effluvium. Okay, there is no alopecia areata. Please remember, in alopecia areata, you will not see diffuse hair loss. You will see patchy hair loss. But in the picture which is shown here, you can see the diffuse hair loss from the crown part of the patient. Clear all of you, because majority of you were wrong. Please give me a thumbs up, Binaya, Kaustubh, Sonali and Naomi, if you understood this question. This is very very important of telogen effluvium. Okay? Now please answer the next question. So post chemotherapy is anagen effluvium. Okay? Post chemotherapy is anagen effluvium. Now the next question is that the patient with psoriasis was started on systemic steroids. After stopping the treatment, patient develops universally red scaly skin with plaque losing their margins all over his body. Which is the most likely cause for causing this disease? Anyone can answer this question. So only Kaustubh is right here. What about the remaining students? So only Kaustubh is right. The correct answer of this question is option number 4. What is erythrodermic psoriasis? It occurs on withdrawal of systemic steroid. The well-defined nature is lost. The well-definedness of the plaque is lost and they become more and more confluent. They combine together and they form the large areas of involvement. That is, more than 90% of the body surface area becomes red, which is associated with scales. And this is called as erythrodermic type of psoriasis. Okay? Can also occur if the patient, yes, you are right, Dr. Kaustubh, even on application of coal tar as well as anthralin, the patient can develop erythrodermic type of psoriasis. Any irritant reaction or any steroid withdrawal will cause erythrodermic psoriasis. So very nice, Ajaya, Kaustubh and all the students who have marked it right. Moving to the next question. Quickly answer this question. 30-year-old female who presents with lacy lesions in the oral cavity, genitalia. Her proximal nail fold have extended onto the nail bed. What is the most likely diagnosis? Very nice. So Kaustubh have given me the answer quickly. Sonali, Naga, what about the other students? Please answer everyone. Please remember, this is a classical case of lichen planus. And what is this clinical feature? Can you tell me, Kaustubh, which type of pterygium is this? Which type of pterygium? So this is dorsal pterygium. Now what do you mean by pterygium? The proximal nail fold, it goes and it get attached to the nail bed. So that is called as dorsal pterygium. Can anybody tell me what is ventral pterygium and in which dermatological condition you will see ventral pterygium? Can anybody answer this question for me? I have told that dorsal pterygium is a feature of lichen planus. So can anybody tell me in which condition you will see ventral pterygium Anyone can answer this? Ajay, Vivekanand, Kaustubh, Sonali, Naomi, Naga, Ajaya, can you tell me? Yes, the correct answer is systemic sclerosis. In patient of systemic sclerosis, instead of proximal skin, there is the distant skin which get fused. So this is called as ventral pterygium, and when the proximal fold get fused with the nail bed, it is called as dorsal pterygium. Okay? So the answer is systemic sclerosis. Moving to the next question. Quickly answer this question, a very very long question. Please answer this question, all my students. Please quickly answer this question. A 53-year-old lady presents to the medical assessment unit with a flu-like illness and myalgia. In the last few days, she has noticed a rash across her back. She has no other symptoms. On examination, she looks unwell. There is erythematous rash across her back and she has a grade 4 or grade 5 weakness which is proximal. Her CK, which is elevated at 1052, and the renal function tests are normal. Very nice. So whenever you see presence of proximal muscle weakness along with the cutaneous feature, it becomes a case of dermatomyositis. And what are the cutaneous features of dermatomyositis? So cutaneous features of dermatomyositis is Gotron's papule or plaque. Gotron papule or plaque. The next is Scholl sign. The next is heliotrope rash. The next is Holster sign. The next is mechanic hand. You have nail fold capillary changes. So these are some of the cutaneous features which is seen. Yes, even calcinosis. So this is a classical example of dermatomyositis. Please answer the next question. A 45-year-old patient had multiple hypoaesthetic lesions with elevated margin present on the trunk. The nerves are enlarged but only of right hand side. What is the most probable diagnosis? Can anybody answer this question for me? Lepromatous leprosy, borderline tuberculoid, or borderline lepromatous? Can anybody answer this question? 45-year-old male had multiple hypoaesthetic lesions. What is the correct answer of this question? Anyone can answer this for me? So Naomi says it is lepromatous leprosy. How many of you agrees with the lepromatous leprosy? How many of you agrees with lepromatous leprosy? Very nice. The correct answer of this question is borderline lepromatous leprosy. Very nice, Binayak. Now please remember, all the students, why it is borderline lepromatous leprosy. The reason is, whenever you see multiple lesions, it means that it should be either BL or LL. But whenever they write hypoaesthesia, it can never be lepromatous leprosy. Why? Because in lepromatous leprosy, because of absence of the cell mediated immunity, the nerve damage is minimum. The nerve damage is minimum in the patient of lepromatous leprosy. It is seen only in borderline leprosy, which is having multiple hypoaesthetic lesions. Please give me a thumbs up, all of you, if you understood one of the very very important topic for your exam. Everyone give me a thumbs up. Whenever they give you loss of sensation, it cannot be a lepromatous leprosy. It should be borderline leprosy because the lesions are multiple here. Okay? Now let's do another question. Please answer this question, all of you. Please answer this question. I hope you can see them. Please answer this question. Check the MDT schedule in the adult leprosy and mark the correct option. So can anybody tell me what is the correct option here? What is the MDT schedule in the adult leprosy patients? Check the MDT schedule in the adult leprosy and mark the correct option. Can anybody tell me what is correct here? Sonali says it is A, B and D. Okay. What about other students? Vivekananda says it is 4. Okay. What about other students? So very nice, Sonali, Binayak. The correct answer of this question is option number 1. Rifampicin 600 mg once a month, that is true. Clofazamine 300 mg once a month, that is also correct. But Depson should be given 100 mg daily and clofazamine should be given 50 mg daily. So all of them are correct except option number C. Okay, so Depson has to be given in a dose of 100 mg per day. It should not be given in the dose of 50 mg. It should be given 100 mg. Okay, I think this is clear to all of you. Moving to the next question, the X-ray finding in the patient of systemic lupus erythematosus. What is the X-ray finding showing here? What does the X-ray of a patient of SLE presents to you with? Fracture femur, fracture iliac crust, osteoporosis or avascular necrosis of the femur. So Naga, please remember Depson has to be given unsupervised or non-supervised every day. Okay? And I think this is a very easy question. You can see that here, where is the pen? If you look at this place, there is avascular necrosis of the femur which is seen very frequently in the patient of systemic lupus erythematosus. What is it? Avascular necrosis seen very frequently in the patients of systemic lupus erythematosus. So I think this is easy, nothing to explain. I'll move to the next question. Lesion over the ear is classical of. Anyone can answer this question. Where will you see the lesions which is seen here in this patient? Very nice, Sonali, Naomi. So please remember, you are partially right. The correct answer of this question is CCLE, which is also called as chronic cutaneous lupus erythematosus. Chronic cutaneous lupus erythematosus. And what is this sign called as? Anyone can tell me what is the name of this sign? This is called as Schuster sign. Okay, so this is called as Schuster sign, very classical of CCLE, which is also called as DLE. Okay, everyone give me a thumbs up if you understood this. Moving to second question, digital gangrene is most likely to be seen in. In which condition you will see digital gangrene? Morphia, systemic sclerosis, CCLE or rheumatoid arthritis. Where will you see the digital gangrene in which of the following patient? Can you answer, everyone? Please answer this question. Digital gangrene is most likely to be seen in morphia, systemic sclerosis, CCLE or rheumatoid arthritis. Very nice. So please remember, this is a characteristic feature of systemic sclerosis and it is seen more frequently in the localized type of systemic sclerosis which is associated with CREST syndrome. Okay, so the correct answer is option number 2, that is systemic sclerosis. Now periorbital ecchymosis occurring bilaterally with associated feature of multiple myeloma should raise the suspicion of. Please answer this question. Raccoon sign with associated feature of multiple myeloma should raise the suspicion of. What is the answer in this question? Very nice, Kaustubh. What about you, Sonali, Naga, Naomi, Vivekananda? Very nice, Binayak. You are right. Vivekananda is also right. The correct answer is systemic amyloidosis. Please remember, primary systemic amyloidosis, which is seen in the patients of multiple myeloma, you have deposition of the abnormally folded light chain, light chain of the antibodies in the patients of multiple myeloma inside the bone marrow, leading to decrease in the thrombocytes, and this thrombocytopenia will give rise to periorbital ecchymosis, very frequently seen in the patients of primary systemic amyloidosis. Okay, option number 1. Identify the signs seen in the paraneoplastic syndromes which can also be associated with obesity and metabolic disorder. Can you answer this? You have to tell me the sign which is seen in the patients of paraneoplastic syndrome also associated with obesity and metabolic. Anyone can answer this question? Kaustubh, Vivekananda, Binayak, Naga, anyone can answer? Yes, very nice, Nayobi, Kaustubh. This is the correct answer here is Acanthosis nigricans. There are two types of Acanthosis nigricans, benign and second is malignant. Benign is seen in young children which is associated with metabolic syndrome. What do you mean by metabolic syndrome? Like obesity, PCOS or hypertension, diabetes, and it is in malignant individual it is seen in old and associated with gastric carcinoma. Okay, so please remember this is very important, and I request everyone to please get my subscription if you are not able to solve these type of questions. Moving to the next question, quickly answer this question. Identify the clinical condition in the image which produces rippled pattern. Where do you see the rippled pattern in dermatology? Prurigo pigmentosa, confluent reticulate papillomatosis, Pityriasis versicolor or macular amyloidosis. So identify the clinical conditions in the image producing rippled pattern. Can anybody answer this for me? Very nice, very nice. So I think nobody have answered it correctly. The correct answer is macular amyloidosis. Macular amyloidosis is an example of cutaneous amyloidosis. Cutaneous amyloidosis means in these the abnormally folded proteins, it gets deposited only in the skin. You do not see any visceral involvement by the amyloid protein, and the characteristic presentation is macular amyloidosis which have rippled pattern and papular amyloidosis which presents with multiple papules on them. Okay, so this is very important that the correct answer is option number 4, that is macular amyloidosis. Moving to the next question, which of the following investigation is unlikely to help arrive at a diagnosis in this patient? So which of the following investigation is unlikely to help arrive at a diagnosis? Trichogram, potassium hydroxides, wood lamp or culture? Please answer this question, all of you. Which of the following investigation is unlikely to help arrive at a diagnosis in this patient? Trichogram, potassium hydroxide, wood lamp or culture? So which will not help? Please remember the correct answer is option number 1. What is this? This is a classical lesion of tinea, or this is tinea faciae, which is present over the face here. Now in tinea patient there is no role of trichogram. Trichogram means examination of hair. So examining the hair will have no role, but potassium hydroxide you will see the linear arrangements of the hyphae. In Wood's lamp you will see a bluish green fluorescence, and on seborrheic dextrose agar you can culture these patients. Okay, so I hope this is clear to all of you. The correct answer is option number 1, that is trichogram. I think nobody have answered it correctly. Second is layer of skin with maximum desmosome interconnection is depicted by. So I think this is a question which we have already discussed, and I want you all to solve this. You have to tell me whether layer number A, B, C and D presents with maximum desmosome interconnection. Very nice. Anyone else want to answer? Anybody else want to answer this question? Binayak, Kaustubh, Naomi. So the correct answer of this question is option number 2. Please remember, A stands for stratum corneum. B stands for stratum spinosum. C stands for stratum basale, and D stands for the dermis. Among all four, stratum spinosum will have maximum desmosome interconnection. Okay, so I think this is clear that option number 2 is answer for this question. And what is desmosome? They are intercellular adhesion molecules. They attach the two surrounding cells. Now, a patient presents with a lesion as shown. What is the best way to describe the lesion? Quickly answer this question. I want everyone to answer. When a patient presents to you with the clinical lesions as shown here, whether it is a dermatomal presentation, blastoid presentation, linear presentation, or segmental presentation. So can anybody answer this question for me? Naga, Naomi, Kaustubh, Binayak, Lovely Dubey, anyone? Yes, so this is a classical blastoid pattern. Okay? And what is blastoid pattern? It tells you about the migration lines in the process of embryogenesis. So what is this? These are migration line in the process of embryogenesis. So I think everybody, Kaustubh, Naomi, Naga, everyone, Shoshank, everyone is right here. Please answer the next question. Patient present with lesion as shown. What are these scales? Powdery, silvery, mica, or collarette? What are these scales? Anyone? So, no, costume. That patient was not lichen planus. The patient was she was a young adult female with epidermal nevus which follows the Blaschko's line. Okay? And yes, I think everybody understood. Mir Shahid, Naomi, Naga. This is a classical collarette scale which is seen in the patients of Pityriasis rosea. Now in Pityriasis rosea you have a mother patch which is called as herald patch. Herald patch which is called as mother patch. It presents with a classical collarette scales. Now these scales are attached from the distal margin and they are free towards the proximal margin. Okay? So they are attached towards the distal margin and they are free towards the proximal margins, and this is called as collarette scale, like a collar. Okay? So they are like a collar. Please answer this question. The patient presents with blister on the skin. The zinc smear shows the cells as shown. What is the true statement? What is the true statement here? Very nice. Kaustubh, you are right for this question. Very nice. So patient presents with blister on the skin. The zinc smear shows the cell shown below. The correct statement is it is seen in the patients of herpes. Very, very important. Seen in the patients of herpes, that is, this is a multinucleated giant cell. It is a multinucleated giant cell, characteristic feature of herpes patients. Okay? So Binayak, Naomi, Arshu and Kaustubh, everyone is right for this question. Now a child who presents with the following lesions over the chin, what could be the diagnosis? There is presence of yellowish or yellow colored crust. What is the correct answer? Bullous pemphigoid, non-bullous impetigo, pemphigus or erythema multiforme. So very nice. The correct answer is non-bullous impetigo, because in non-bullous impetigo you see honey colored crusting. In non-bullous impetigo, you see a honey-colored crusting, while in bullous impetigo, you see a warnish crust. Okay? And what is the causative agent for non-bullous impetigo? Both streptococcus and staphylococcus, both strep and staph can cause this, but it is seen very frequently with streptococcus. And what is the another name given to the non-bullous impetigo? It is called as impetigo contagiosa. It is called as impetigo contagiosa. That is a feature of non-bullous impetigo. So please give me a thumbs up everyone if you understood this. This is a very, very important question. Now quickly answer this question. I think this is a repeat question. We have discussed this question when we were discussing the dermatology pharmacology correlation. Patient suffering from fever for past 1 week along with mild shortness of breath. He is having single painless lesion as shown in the photograph. What is the most appropriate treatment? Lovely, Dr. Kaustubh, Arshu, anyone can answer this question. Very, very important for your exam. Very, very important for your exam. Can you answer this for me? Very nice. So what can you tell me the diagnosis? So here the diagnosis is the scrub typhus, or this is the bite of the mite, the site of bite of the mite, that is scrub typhus, and the drug of choice is doxycycline. Very nice, Saroj, lovely, Binayak. You all are right that this is a scrub typhus which have bitten over here, and you have to give doxycycline as the treatment of choice. Now going towards the next question, quickly answer this question. A young boy with itchy papules on the forehead, the exposed part of the arm and leg. The disease was most severe in the rainy season, improved completely in the winter. Which is the most likely diagnosis? And yes, Saroj, you are right. Susuga mushi orientalis is the causative agent. But for this question, can you answer? So when you see multiple lesions which are completely improving in winter, what is it? What is the diagnosis when you have complete improvement of the lesions in the winter season? Yes, very nice. It is a classical case of insect bite hypersensitivity. Please remember, atopic dermatitis, it is a chronic disease. So it will not improve completely in the winter. It should be insect bite hypersensitivity which occurs only in the rainy season. Very important. Okay? So this is a point which you all should know, that it occurs during the rainy season. Now identify the organism here. Can you identify this organism for me? Anyone? Can you identify this organism? Scabies mite, Demodex mite, louse or tick? Can anybody identify this organism for me? Scabies, Demodex, louse or tick? Very nice, Saroj, Kaustubh, Naga, Binayak. What about the other students? The correct answer is, this is a classical Demodex species which is the causative agent for rosacea. Okay? So this is a classical Demodex species which is the causative agent for rosacea, which presents with the flushing and telangiectasia over the sun exposed site. Moving to the next question. Quickly answer this question. Patient comes with oval to circular lesions on the trunk. He reports a long-standing fever a few years back. The nerves are normal. What statement is true for this condition? So what you will do in this patient? Can you tell me the diagnosis? Nobody is telling me the correct answer till now. No one. Amrit, Arshu, Shwasank, Naomi, you all are wrong. So whenever a patient gives a history of long-standing fever, can you answer now? In which condition you will have a long-standing fever which is followed by hypopigmented lesion? The answer is, it is an example of post-Kala Azar dermal leishmaniasis. Okay. It is not vitiligo. It is not Pityriasis versicolor. It is a post-Kala Azar dermal leishmaniasis, and they have clearly mentioned that a patient is having a long-standing fever and following which he develops hypopigmented macules. Okay? So the correct answer becomes, you will do a Giemsa stain which will show the LD bodies. Please give me a thumbs up if you understood this question. Moving to the next question. Patient present with the lesion shown. What is the likely pathogen? Very nice. Very nice. Kaustubh, Saroj, Gohar, Arshu. Very nice. All of you. Very nice. So very important question, that a patient when he presents with a lesion This is a classical case of genital wart, which is also called as condyloma acuminata. And condyloma acuminata, it occurs secondary to HPV 6 and 11. I hope this is important for you and you all understood what is this. So this is a classical HPV 6 and 11. And yes, you are right, Saroj, you will give podophylotoxin for the treatment. Now, can you answer this question? Multiple flat skin colored lesions. Please remember, they are skin colored. In which condition you will see skin colored lesions which are increasing gradually? Anyone can answer this question. Which skin colored lesions which will... Yes, very nice. Please remember, this is a classical case of verruca plana. Why it is verruca plana? Because lichen planus is purple in color. But as you can see that they are skin colored lesions. And they are increasing gradually. Please remember, the viral infection, that is verruca plana, will grow very rapidly. So Naomi, Naga, Kaustubh, Lovely, the correct answer of this question becomes option number 3, that is verruca plana. Now quickly answer this question. Identify the type of onychomycosis which is shown in this picture. What type of onychomycosis is this? Just look at the clinical picture, you can answer it. Simply looking at the clinical picture, you can able to answer this question. Yes, the correct answer is, this is a classical distal lateral. Can you see that the distal part of the nail and the lateral part of the nail is getting involved? So this is the most common type of fungal infection of the nail where you have distal and lateral involvement. But the proximal subungual, which is most common in HIV patient, will have involvement of the proximal part here. Okay? And this is seen very frequently in HIV individuals. Can you answer this question? A patient was diagnosed secondary syphilis. He was given an injection, benzathine penicillin. Few hours later, he developed fever, headache, exacerbation of the cutaneous lesion. What is the diagnosis? So you are asking me the treatment of which question? The onychomycosis, you have to give oral antifungals. You can give topical nail lacquers like cyclopyrox or the amrolfin. Okay? So you all are right. The correct answer is Jerish Hexamer reaction, in which you will see the lesion within 24 hours of giving the benzathine penicillin. It is seen very frequently in the infective stages of syphilis, that is primary and secondary syphilis. Okay? So very nice that all of you understood. The most commonly implicated drug in the SJS and 10. The most commonly implicated drug in ART for SJS and 10. What is DRESS? DRESS is drug related or drug rash plus eosinophilia and systemic symptoms. Okay? So the correct answer of this question is option number 1, that is nevirapine. Initially we used to give ZLN, that is zidovudin, lamivudin, nevirapine. But because of side effects of nevirapine, we started giving ZLE. Now because of the anemia which occurs because of zidovudin, we have started giving TLE. So nowadays the ART which is given is tenofovir, lamivudin and efavirenz. Okay? So I think this is clear to all of you. Now please answer this question. A child present with soreness in the mouth, rash in the hand and on the feet as shown in the image. Very nice. The correct answer is, this is a classical example of hand, foot and mouth disease. ठीक है. So this is nothing but a hand, foot and mouth disease which presents with Coxsackie A16. ठीक है. Can you answer this question, all of you? The next question, a child presents with fever, rash as shown in the image. What is the diagnosis? Chicken pox, smallpox, measles or rubella? Very nice, Saroj, Amrit, Arshu. Very nice, all of you. Naga, Karthik. Very nice, everyone. So the correct answer is this is a classical case of chicken pox because fever with pleomorphic rash, and this is a classical dewdrop on rose petal appearance. This is a classical dewdrop on rose petal appearance. Can you answer the next question, everyone, quickly, because we have only 5 minutes left. So quickly answer. The patient comes with the following lesions on his shoulder, chest, scarring in the center, there is increase in the periphery. Which is the most appropriate treatment which can be given in this patient? Yes, very nice, all of you. Anshu, you are right. So what is this? This is whenever you see scarring in the center, it becomes a case of cutaneous TB. And for cutaneous TB, you have to give anti-TB treatment. Okay? So lupus vulgaris is the example here. This is a case of lupus vulgaris with central scarring. Very nice, all of you. Can you solve this question? Can you solve this question? A child present with the dry skin. He has colloidal membrane at the time of birth. What is the correct answer? Very nice. So Saroj, I come every day at 8 p.m. on the Let's Crack NEET PG YouTube channel. You can follow me on Unacademy Learning app. So please use my referral code Chesta10 to unlock all my classes on Unacademy Learning app. Okay. So you can find me every day with many of the free classes on Unacademy app as well as on Let's Crack NEET PG channel. Okay? So the correct answer is lamellar ichthyosis, which presents with the classical colloidal membrane surrounding the fetus or the newborn. So I think we are done with almost all the questions. We are left with few more questions. We will be covering it in the tomorrow sessions. So good night, all of you. If you like my today's class, please give me a thumbs up. Please subscribe to any of the class, or please subscribe to this YouTube channel. You can give me or you can use the referral code Chesta10 for getting subscription on Unacademy. And please don't forget to press the bell icon so that you can get the notification of all the new classes from me. So good night, all of you. We'll meet again tomorrow with... So thank you, Saroj, if you like it. And if you have subscribed, please use my referral code Chesta10. This is very important. You have to use my referral code Chesta10 for subscription. So bye-bye and take care.